I don't know.
Oh, there you go. Someone beat us to it. Awesome.
Yeah, so I'll start the case. And so it's a long case. I'll be loyal to what happened in the reality. That's a case that I saw during one of my surveys. So to start, the chief complaint is fatigue and recurrent low-grade fevers. So for the HPI, we have a 74-year-old male with a past medical history of immune thrombocytopenic purpura, hyperlipidemia, and glaucoma, who presented for fatigue and recurrent low-grade fevers. So before I announce out loud what happened during the hospitalization, I should say to you guys what happened in the previous hospitalization. So, like 2 weeks before the patient to presenting the ED, he was hospitalized, and in the previous hospitalization, he presented with chest heaviness, non-productive cough, fatigue, weakness, and weakness for 3 weeks. I will say what happened during the previous hospitalization. Okay, so regards labs and everything. All right. So the chest X-ray in the previous hospitalization showed just like subsegmental opacities in the left lung. He also was submitted to a CT of the head that showed acute sinusitis. And just an addendum, I will paste all this information in the chat so you guys can process and discuss in a more appropriate manner. Other than that, the patient was submitted to an extensive infectious workup and HIV, hepatitis A, B, C, EBV, uh, and EBV IgM was negative and IgG was positive, but the DNA was ABV DNA was negative. Toxoplasma serology, ehrlichiosis, Lyme, Babesia, Bartonella, Q fever, CMV, MRSA, and Group A, strep. All those infections were negative. Mm, Other than that, the patient was submitted to a lumbar puncture that was non-remarkable. Um, they also did a rheumatologic workup that was negative for rheumatoid factor, NP, SSA, SSB, anti-nuclear antibody screen, anti-Jo, JAK2 mutations, all this stuff. Well, the pertinent positives we have an ESR that was 220, a CRP of 21.6. And at that point, the patient was treated with Zosyn and doxycycline. And at some point of the hospitalization, they scalinated for vancomycin, and they tried to use and also ampicillin, ceftriaxone, and also micafungin. But the patient developed adverse reactions such as eye irritation and diffuse muscle pain while on micafungin. Then they tried to start steroids, but the patient presented also hallucinations and delirium for the steroids. Okay, I'll stop here. That's a lot of information.
Oh my gosh. I hope
Yeah. Do you
everyone.
want me to summarize a little bit?
No, that's okay. I guess
That's okay.
maybe we could do
Okay.
the summarizing, but just to help make progress with the reasoning. But gosh, I hope everybody is as overwhelmed as I am.
I'm there. Yeah.
Good. Thanks for always been having my back, Steph. Um, no, it's obviously a case that already is extremely complicated, has had a lot of excellent, appropriate workup, and we don't have an answer. So we're starting at a point of kind of uncommonness. We're starting at a point of kind of complexity and a lot of noise as well as some signal. And we already have a lot of work to do to try to um, eh, like represent the problem appropriately, right? So we have enough information actually now to, I think Vinny, you're right that we kind of need a summary, but you did a lot of hard work, and it could help for someone else to just try to synthesize or kind of pull out what stood out most. So maybe everybody can just kind of take a minute to process everything. I certainly need a minute, and then if somebody wants to kind of offer a problem representation, um, that would be great.
One clarifying question, Vinny, were there also fevers present this day, or is that only now that he's back that he's having fevers?
No, he always had like the intermittent fevers, both on this presentation and also in the past presentation. And just to you guys can put like all the things all together, it is important to say that after they tried the steroids and the patient had hallucination, he started to getting better, and they couldn't figure it out what was happening to the patient. But due to clinical stability, they decided to proceed with discharge and then subsequent follow-up. So that's where we are now.
Thanks, Vinny. So, David, you're sort of calling this FUO, but do you mind, I guess, just mentioning any other kind of distinguishing characteristics that you would also um, mention in like a problem representation, or if you just want to list this is fever plus what, or like systemic inflammatory syndrome plus what? Like, is there anything that can actually help us sort of potentially localize or recognize a sort of a unique signature of a particular disease?
It seems to be a long history, so here's it's not always easy to know what is just a complication of the hospitalization and what is the primary feature in the syndrome. Seems to be left lung opacity and sinusitis and also DVT. But for example, I wouldn't want into hypercoagulable disorders at first and think likely that DVT is not part of the primary syndrome, but we have to still see how it develops.
Yeah.
Yeah, beautifully said. Other than systemic inflammation, I'm at the same plate that you are, David, of, the cough and chest discomfort are a source. And one, as he's been worked up for a lot of sort of different systemic infections, thinking about which have predilection for the lungs. And as we get to meet him again, if it wasn't done before, although it may have been, if he hasn't had more detailed imaging of his lungs to better look at what are those kind of lower lung kind of opacities that were called subsegmental. I don't know if that was X-ray or CT, Vinny, but seeing how that progresses, if in fact his pulmonary syndrome does also, might just give us both a place to anchor a syndrome that is a systemic inflammation with a lot of pulmonary issues, and with this incredibly detailed workup that's been done, help us figure out what to do next to figure this out when it comes to tissue sampling, biopsy, etc. So I don't know, Vinny, can you clarify? Did he actually get a chest CT, and that's what showed kind of the basilar abnormalities? Because I don't want to anchor too much that this is sort of a pulmonary systemic inflammation syndrome. We may not have that information.
Yeah, so the lung findings was primarily in the chest X-ray.
Mm.
I don't have. It's been a while that I saw the case. I don't have the chest CT from the first hospitalization, but I can. I will give you the chest CT of this hospitalization in the future. Is that okay?
Yeah, which I really do want a chest CT for this hospitalization for a couple of reasons.
Yeah,
One is to better characterize the lung parenchymal disease, but with this clot in the leg, even though it's subpopliteal, um, and some pulmonary symptoms being present, you just want to make sure that there's not also a clot in the lungs. Now, I don't know if that would supposedly venous thromboembolism clots can cause fevers. I've heard of cases, I don't know if I've ever seen it, but just like there's more to it than that, right? Like this degree of systemic inflammation, it's more likely that it caused thrombosis rather than that the thrombosis is causing it. But just to know whether the pulmonary symptoms are still potentially a localizing source of the inflammation or part of the systemic signature of the inflammation, it would be good to know whether this person has a PE, even a small one. Um, and yeah, and then what do y'all think of this of the sinuses? Is that signal or noise?
Yeah, I was thinking about that a little bit. Hard to say. At least at this point, we don't hear about any comorbidities that put them at risk for invasive sinusitis from fungal disease, for example, but certainly chronic sinusitis from bacterial causes as well. I'm particularly thinking of factors like uncontrolled diabetes, heavy recent prolonged steroids. Now, we heard that he got steroids this hospital stay, but in the absence of a lot of kind of steroids in the past, I think lower risk. And then any kind of neutropenia or just dysfunction of the neutrophils, of course, also puts people at risk for more serious sinus disease. Again, we don't know that those are present yet. If you think on your career so far of the number of head CTs that you had that showed there was sinus disease there, it's a lot. But I do think it's a great point, Zavin, because in this person with fever that we can't figure it out, if that hasn't been asked about, right? The first test to do will be to ask him more history of symptoms, any nasal discharge, etc. That's kind of important because in these cases where someone's had a huge workup, you still can't figure out what's going on, and now you're the next person to think about them. A critical first step is reevaluating the whole history again and really getting into the details of some of the prior data, which takes a long time, but is very valuable to do to pick up things like this.
Totally. I think like if this patient was somebody with sustained neutropenia, right? Like both the sinuses and the lungs would immediately just like that would be the answer without even any thought, right? It would be this is invasive fungal infection, it's aspergillus, or if this patient was someone with poorly controlled diabetes and maybe ketosis, like this would be Mucor, right? And we want a very close exam, endoscopic exam by ENT. Like we would just very much go in that direction. But right now it's still very nonspecific, only because we don't have those risk factors that we know of, right? But it's also important to keep in mind that those tight associations with certain risk factors, a lot of those diseases can much more rarely occur without those risk factors as well. And maybe the risk factor is age, or maybe this is a fungal infection. Someone was asking in the chat, sort of, I had assumed this patient was in Brazil, Vinny, but it sounds like they were in, this was a patient in Ohio.
yeah, correct. That's
Okay.
from Ohio.
I was wondering about other rickettsial testing, and I thought, oh, that's a new distribution for me for Lyme disease.
Well, so this is something to keep in mind that so rickettsia are pretty much everywhere in the
Yeah.
world. They're different rickettsia, right? But there are doxycycline deficient states everywhere in the world. And similarly, dimorphic fungi, sort of endemic mycoses, are different in different parts of the country, in the US and in the world, but they exist in most places, right?
Yeah.
So whether in Ohio or in South America, you would want to think about, whether it's histo in this case, blasto versus paracoxy or something else in a different place. But yeah, just like TB remains kind of in the differential of FUO with potentially sort of air exposed places or any localizing sign, so does histo. The last thing I want to say is I'm also wondering about this sort of myalgia and the eye irritation, because when I hear that it was attributed to mycofungin, in a hospital, two things come to mind. I've never heard of those side effects, but it doesn't mean they don't exist and they're not real. But even if it is a potential side effect, I think so many things happen in the hospital at the same time, and everybody's so complicated that a lot of times we assume causality just from temporal association, when it's in fact coincidence or a different thing. Was this a microfungin-induced side effect, or was this just actually going to happen anyway, and it's actually part of the signature of the systemic inflammatory disorder, right? So if there was a prominent muscle symptoms, again, that can happen in any inflammatory state, but I would want to just see if there's a lot of muscle injury, if there's CK elevation, dysfunction, objective weakness, etc., that could make this sort of systemic inflammation plus myositis, right? And kind of potentially enrich for certain rheumatologic disorders. Or if there's uveitis plus systemic inflammation, some mycobacteria, endemic fungi, sarcoidosis, like it would enrich for a different certain kind of spondyloarthropathies, and would become more likely Behçet's potentially. I would still track those as potential signals, and certainly have an extremely high. Just want to ask and just keep an eye on, and if anything like that pops up again, now that we're off the mycofungin, I would very much treat that as a helpful clue.
That was only aliquot one, Vinny, and we've got a lot more.
You warned us it's a long
Yeah,
time.
you told us. Let's get some more.
Yeah, absolutely. So just one thing that is important also is in the first hospitalization, due to the fact that they are looking for possible etiologies, they was not finding any clear etiology. The patient was also submitted to a bone marrow biopsy that revealed the abnormal megakaryocyte with a 50% cellular bone marrow. And we'll get more details about this bone biopsy after. But on this presentation in the ED, like the patient comes again with the same symptoms of the previous hospitalization, so chest heaviness, non-productive cough, fatigue for almost 5 weeks. And on evaluation, the patient endorses that since discharge, he has the continued fatigue and progression of the symptoms, endorses nausea and vomiting with weight loss of 15 pounds over the last month without changes to bowel movements. He endorses occasional mild headache, endorsing a bilateral frontal headache. He denies pain in temples, vision changes or vision loss, denies also pain with chewing, denies changes in hearing or weakness in the shoulders or hips. What he endorses a continued unproductive cough, and denies also hemoptysis, and endorses nosebleeds with trace blood when blowing the nose, and does use a nasal decongestant called Afrin. So regards past medical history, I already said that medication was just taken rosuvastatin prior the before hospitalization for the hyperlipidemia. Family history, non-contributory, does not smoke, does not use drugs or alcohol, and denies any allergies. So regards, I'm sorry about the noise outside. I will just move on. Regards
Yeah,
physical
actually
exam.
sounds great. I don't hear any noise, so keep going. You're doing great.
Okay, sure. Regards the physical exam, the blood pressure is 90 over 55. The patient is stable. Pulse is 80. Temperature, it's 97.4. Respiratory rate is 18. No episodes of desaturation, saturating 97% on room air. And I will just announce out loud what is burden in the physical exam. Okay, so like bilateral. It's that there's 2+ bilateral temporal pulses, and yeah, nothing more. Like extremities normal, narrow, all cranial nerves normal, everything normal in physical exam. Do you want to stop here, or should I give you the initial labs?
I just want to ask, there's palpable pulses, any tenderness or kind of visible enlargement of the arteries?
No, no visible enlargement of the arteries, no tenderness at palpation, and yeah, that's it.
Great.
I think, yeah, go
Mhm.
ahead and give us the initial labs to kind of frame everything that's going on.
Could we, I don't
Sure.
know if I missed this, Vinny, I'm sorry, but could we just hear a little bit more about, like, I guess what he did with the steroids? Is he still taking them? Were they tapered off? And then just his like baseline meds for ITP, just is he on anything else immunocompromising, things like that?
Yeah, so no other than the rosuvastatin, no other
Oh,
medications, and the prednisone, he was just taking. He received 60 milligrams on discharge, and it was instructed to him to follow up, and then he presented again like 1 week after. So yeah, he was on Pred 60.
and like the
Yeah.
ITP, he didn't get like rituximab 4 months ago or something like that.
No, no, there's no, how can I say that? History of taking any kind of meds for the ITP.
Okay, cool. Thank you. Yeah, I think basic labs is I'm good with that too.
Mhm.
Sure, absolutely. So WBC of 16 with a neutrophilic differential and an absolute neutrophil count of 13.5 at this point. The hemoglobin was 10.2, hematocrit of 30, and the baseline is also around 10 of the hemoglobin, right? With normal MCV 89, like RDW of 14, reticulocyte count of 1.1. Let me see what else. Platelets 160, INR of 1.3, and metabolic panel sodium of 135, potassium of 4.2, chloride 95, creatinine 1.3 with a baseline of 1.1, calcium normal at 8.8. Yeah, give me some minutes. Alkaline phosphatase of 213, a little bit elevated. CK of 19. Protein of 6. Yeah, I'll stop here.
Great. Thanks, Vinny. So coming back to us a week after a long stay for cough and systemic inflammation with no clear etiology and a temporary course of high-dose steroids, he still is having systemic inflammation with the cough and mild headache. Um, just a couple points I'll make before jumping in. Giant cell arteritis has been brought up several times in the chat, I think very appropriately so. Some of the discussion has been sort of weighing, how does the absence of some of the actual irritation symptoms of the temporal artery factor into it? And it's great to see people saying it's really still on the table. This systemic inflammation with very mild headache, high inflammatory markers in this gentleman who's over age 50 is really, again, a picture that could fit for that. I do think it's an interesting discussion. A week of prednisone at 60 milligrams not making things start be a little better is striking, I would say. But I think really important that people have highlighted that syndrome really hasn't been kind of ruled out yet. But now we have this sort of test of how does he feel on steroids. And the answer is not that much better, interestingly.
Is that right? I thought he felt
Did you say he
no
felt
better or like a little better and then it just came back?
So he, like, when he was discharged, he was better because he received the pulse on admission on the previous hospitalization, but had the hallucination, and then they decided to decrease the dose. And when he was discharged, he was feeling good. He was like clinically stable, but he was discharged on the pred like 60 and was supposed to do the taper. But then, like, when he was about to decrease the dosage, he started to feel worse again.
Mm-hmm.
Is that is
And,
that clear?
yeah, and that can definitely happen with, with GCA. I um sort of saw a patient who kind of had a really good response on 60 milligrams, for example. This was a long time ago, but every time he would try to taper to 50, this was before IL-6 inhibitors and all this stuff, but when he would try to taper to 50, his headache would just come back. He would have, and so I think it fits. And the other thing I was just reflecting on in terms of like just kind of it making sense why GCA can present with FUO is that the symptoms of large vessel vasculitis, the most common symptoms that we think of are ischemic symptoms, right? So it's vasculitis wall thickening to such an extent so as to narrow the lumen and cause essentially stable angina of your chewing muscles, right? Or for the, inflamed, again, narrowed, turbulent, um, clot-prone endothelium to form clots and throw them into your eyeballs and cause intermittent amaurosis fugax, right? But you can have the initial stage of severe inflammation that just hasn't come to a point yet of luminal narrowing. And the vasculitis is very much there. The systemic inflammation is there. You're just not seeing those focal signs of ischemia. So anyway, so I think aortitis, vasculitis, large vessel or medium or small, without yet kind of end organ effects that are like slam dunks is very much possible. But I also don't necessarily want to anchor that too much because most manifestations of infections are also via the immune system, and steroids could initially make you feel better even if you do have an infection too. And I do want to just kind of point out the ALK-Phos too. I think I saw it fly by in the chat, but I never ignore an ALK-Phos of 200, especially when, I mean, just never, period. But in this case, it could be the clue. It's just not normal. It could localize to the liver. We definitely need good liver imaging. But it could just represent an infiltrative process of the liver too that doesn't show up on imaging. And it could also be a signal for sort of bone pathology that fits with this systemic inflammatory syndrome. So I'd love to kind of get the follow-up liver imaging as well as either fractionation of the ALK-Phos or a GGT, 5' nucleositis, whatever helps us kind of see, is this a liver ALK-Phos or a bone.
And really with the exam and the labs, other than the ALK-Phos, not point us anywhere. If he hasn't had cross-sectional imaging, chest, abdomen, pelvis, now's the time. Because as we get into week 5 of this illness, where this guy doesn't feel great, actually having that in there. And later, if we're going to be layering it on with the PET CT also, to be able to see what is inflamed is going to be really important. But maybe we should get some more from you, Vinny, and we'll keep the discussion going.
Yeah, absolutely. Loving the discussion in the chat and all the comments. So following the labs, we have a 13 of more than 1,000. We have an uptrending CRP that's now 28. The ESR in this hospitalization is still high, 120. C3 normal with C4 decreased. The iron is low, TIBC low, and transferrin saturation low. HIV again negative. MPO negative. PANCA and CANCA negative again. IgG4 was high at 220. Syphilis was not reactive. Kappa lambda ratio was normal. I'm trying to keep things organized as much as I can, but it's hard with a lot of information. Okay, anticardiolipin was normal. ANA was negative. BCR ABL was undetected. JAK2 mutation again was no variant detected. Let's see. On there was just the DM spike in the I just forgot the exam, but again was normal. They did also respiratory pathogen panel was negative. Tested for tularemia was negative. Let's see again. Okay, so some imaging now. The chest X-ray shows no acute abnormality at this point. Answering about the chest CT that was performed now, there is right upper lobe and centrilobular nodules, likely infection/inflammatory changes, but and also with a small left pleural effusion. CT of the face shows circumferential thickening of the left proximal pseudoclavian, and also distal common carotid artery. These finds raises the suspicion for vasculitis. And the ultrasound of the temporal artery reveals no sonographic halo sign was identified. And by the ultrasound, there's no evidence of giant serotoridid by sonographic criteria. I'll stop here.
I just want to make sure I heard, Vinny, the subclavian finding on the CT. Do you mind just saying that again?
Yeah, absolutely. So circumferential thickening of the left proximal subclavian and left mid through distal common carotid artery. That's it. No stenosis, and they commented that finds are non-specific but raise concern for underlying vasculitis.
Yeah, agree with radiology, particularly in the context of this syndrome, right? Systemic inflammation, we've been worried about vascular inflammation, and here we have some pretty large arteries, the subclavian and the carotid, that show some abnormalities that I think really we need tissue. Like, I think at this point, this guy, again, he's been on steroids about a week or so. There really should be some diagnostic yield, knowing the limited sensitivity of some of the temporal artery testing that he's had. Curious what people will say in the chat, but I think that is really, really important. We can get a proxy if that's not physically possible or non-diagnostic of whether those findings in the subclavian and the internal carotid artery are inflammatory with PET CT. We talked before about looking for that, and those will be kind of bright and lit up if that's the case. But I think really sort of compelling for this potentially to be a vascular inflammation syndrome, as we talked about. I think we got something out of that. I would follow that track on this guy.
Yeah.
So helpful to get that data.
I'm thinking just a step ahead. It's like, okay, if it is pet avid, right? Um, that'll just confirm that we have a large vessel vasculitis.
Mm-hmm.
It'll help a little bit to, again, there's non-inflammatory vasculopathies, right? Like, so for example, just fibromuscular dysplasia, if this patient was younger and female and very commonly involves the carotids too, not just the renal arteries, just as an example. But we already knew this was an inflammatory syndrome. So if we think this is signal, if we're following this, we're already in the large vessel vasculitis space. GCA is the most common, right? But and this is the patient for it, right? Older white male as opposed to a middle-aged or younger Asian woman, right? That would make you think of Takayasu disease, for example. But just other, IgG4 disease can cause large vessel vasculitis. Behçet's can affect any size vessel. So some of this is about kind of epidemiology and base rate, but I would also be trying to sort of tease out any other distinguishing characteristics that would favor one versus the other, right? So is that serum IgG4 that's elevated helpful? I forget what the upper limit of normal is. I know that's not a particularly sensitive finding. It's only elevated in like what, half or two-thirds of people with IgG4 related disease. But is it specific? I don't think it is either. But I would want to learn more about like, yeah, sort of what the test characteristics of that are when it is elevated, whether sort of looking more deeply at sort of all of the IgG4 subclasses and kind of comparing the values is helpful at all. I mean, this is definitely a space where you need a lot of specialty input because, you could biopsy the temporal arteries, fine, but like just what if it's negative? And it very much might be because he's
Yeah.
not localizing there symptomatically with a headache, right? On exam, the ultrasound is something, even though it's not perfect, right? So you would just sort of like fall further and further behind
Yeah.
if you did a bilateral biopsy and it was negative. It wouldn't rule out GCA, right? With just proximal vascular involvement. It certainly wouldn't tell you if it's another kind of vasculitis. So just like talking to radiologists and trying to again discern, tease out, are there any features that are, yeah, like more specific, talking to rheumatology and seeing kind of what they make, both of the clinical features, the radiographic, the labs we have so far. In the meantime, in parallel, you should be thinking about management, right? You don't want to delay treatment, but you also kind of want to weigh with whether how important it is to have a specific diagnosis and what the sort of decay factor of diminishing returns on further diagnostic tests is going to be. You're not going to biopsy a carotid. That's the thing, right? You're not going to biopsy a subclavian either. We biopsy temporal arteries just because I guess there's some redundancy in the blood flow, and then like it's pretty much the most compressible artery, isn't it? It's literally like under the skin, right above a bone, where you can just push on it and or whatever. I guess they surgically ligate it too, but um, anyway, I think tissue might just be hard, which is why my mind is kind of in the space of like, is can we make a diagnosis without it? But certainly would be nice to have tissue.
Yeah, well, love it. Absolutely. I will share my screen because now we have a CTA of the chest, and that led us to subsequent further testing. Okay. Let me see
I know,
that.
Yusuf. I'm I'm scared. Um, I wonder if we're gonna just 180 U-turn on this one, or if yeah, it's gonna be a big old donut of an aorta. Well, no, a descending aorta.
Oh, okay. So I was trying to look and look and look about the CT, and it was really, really high really, really hard for me to see something here, but trust me, there is something here. And also, there is a more subtle thing here. And I will proceed with further testing, and then I will read all the results from radiology. And due to the concern of this, can you guys see my pointer?
Yep.
Okay.
Okay.
So right here, they were concerned for the specific the thickening of the aorta here, and also cleaving. And here was very hard to find for me, but here I think that's more clear. There is like a difference in the color. I don't know if it's echogenicity they call whatever. So there's a difference in color here. So then we proceeded with the PET scan, and now everything's like pretty clear. So these are the imagings. Thank you. Okay, and let's see what they announced about. The official rating was perivascular from the CTA, perivascular soft tissue thickening involving the aortic arch and proximal great vessels without definite narrowing concerning for vasculitis, and PET CT increased vascular wall activity involving the ascending aorta, also aortic arch. Oh, yeah, and proximal great vessels also. So, and I just want to remind you guys that in the previous hospitalization, the patient was submitted to the bone marrow biopsy that revealed the hypercellular marrow with tree lineage hematopoiesis, with decreased erythroid precursors and some megakaryocyte maturation abnormalities. And these findings are consistent also for myelodysplastic syndrome with low blasts. So I'll stop here, leave you guys comment some things, and then I'll give my perspective.
Thank you. So I think we've got a word now, right? We've got aortitis, and the question is what's causing it? We've talked a lot about the sort of idiopathic inflammatory vasculitides that affect large vessels, GCA being our biggest worry in this guy because of his age. Certainly, if it were someone younger than 50, we'd be worried about Takayasu aortitis. But I guess the question is, what else inflames the aorta besides those vascular processes? You can get infectious or malignant infiltration of the aorta with his extensive evaluation that he's had without thus far kind of known clonal entities in his blood, or again, worry about systemic kind of infection that could have caused an infectious aortitis seems less likely. But the same way we apply our kind of approach to fever being infectious, inflammatory, malignant, honestly, that can go for inflammation of any sites, including the aorta here. But I think infectious and malignant infiltrative etiologies are unlikely. And then I think sort of signaling us back to bone marrow biopsy, Benny, is really helpful. Like, how is there an overlap here? And I saw earlier in the chat question of the autoimmune inflammatory syndrome, sort of VEXIS coming up, which is based on genetic testing, based on bone marrow abnormalities. Something I didn't know is that it can involve the vessels and be sort of a GCA mimic, actually. And the way to actually confirm that diagnosis would be with genetic testing and certain stains on the bone marrow. It's kind of interesting what's missing on that. This autoinflammatory syndrome usually has a signature that you see outward in skin changes, and they can really look like a million different things. Chondritis is a common, I shouldn't say common, but of an outward symptom that you can see in it, right? Inflammation of the nose or the cartilage. So it just strikes me that there's not any sort of cutaneous or cartilaginous sort of inflammatory signal, but was just kind of quickly reviewing criteria for that syndrome. And seems like the sort of mimic of GCA is something where you should really consider it, particularly when there is an underlying signal of kind of MDS or MDS-like bone marrow. But I'm struck by some of the lack of sort of the outward inflammatory signs that are really very common in that condition. Aortitis NOS.
Yeah.
Other things you have to add?
I want to learn more from Yusuf about Erdheim-Chester disease.
I think, like you said, enlarged aorta can be caused by inflammation or vascular disease, but it can also be infiltrated, and it can be infiltrated by like infections. But it can also be infiltrated by molecules. The molecules include IgG4, but the other one is Erdheim-Chester. But I think I would want to look and see like characteristic findings on imaging, and otherwise it would be like a pathological diagnosis, which is like the hairy kidneys, etc.
Yeah, and I wonder if we relook, it's going to be hard to get a piece of the aorta. Can we relook at the bone marrow biopsy we have, right? And see, is there histiocytic infiltration, right? Are there some of these signs of what we're wondering could also be infiltrating the aorta? Like we have some tissue, so maybe we relook at that as the approach, since this is a hard place to biopsy.
Yeah, I think that again, I'm in this space of like the information that we have, what if the answer is already there? And whether that just takes like somebody more experienced or knowledgeable looking at the same information, or if we just need to revisit and ask slightly different questions about like the data points we already have, including again path radiology or the labs. What a fascinating case. Vinny, do you want to, I guess, move us forward, just being mindful of time, or do you want us to kind of discuss more? Is there more, or will the next aliquot reveal the diagnosis?
No, the next aliquot will the diagnose. I think that we are in a good space for me. I'll give you a few words, and your collocation is beautiful, beautiful, because like what we were facing at that point during rounds and discussing the case is so like if the ultrasound of the temporal artery it's negative, it's a low pretest probability of having a giant arteritis, and should we like the patient already was submitted to an extensive workup, should we do all the thing again? And we are getting out of resources, like not in a clinical perspective, of a knowledge-based perspective, but how like put things together and try to differentiate between what is signal and what is noise. Like the IgG4 that was high, or the pleural the nodules in the lungs, or just the small pleural effusion and all the things. So in the end, we considered it like both hematology, oncology, and rheumatology. And the rheumatology just thought us that there's no need for the ultrasound to be like to have the halo sign present. So there is the aortitis there. Guy has the inflammatory markers elevated. There's no suspicion for microscopic polyangiitis or some small vessel vasculitis. It's pretty clear that it's a large vessel vasculitis, and they concluded that this is indeed the giant cell arteritis. So at that point, due to the like hallucinations that the patient faced, they were more skeptic with the initiation of steroids, but they uptrended the dosage again. But by this time, the patient did not experience any kind of hallucinations, and they were studying the possibility to start I think that is tocilizumab. I don't remember the specific drug. But yeah, that's the case. What's a huge discussion between like subspecialties and hemonc and consulting other teams. So thank you guys.
What a case, what a journey. Thank you, Vinny. That was just a great way to kind of get into both fever of unknown origin and, reconciling a lot of these labs, and then the getting into aortitis. Thanks for sharing that. Anything you want to say before we hear some review from Sasan?
Just acknowledging that Mark and others are potentially wondering about still there being some diagnostic uncertainty, which it seems like Vinny's colleagues also, we're in that we're in that space, and specifically the pulmonary abnormalities, whether that's a feature of GCA versus other causes of large vasculitis. Vinny, you wanted to say something about that, or?
Yeah. No, our we haven't dive in depth about the pulmonary nodules. We thought that they were present there in the previous like imaging exams, and was not very concerning that like yeah, like there was a better explanation for the clinical picture than the pulmonary nodules. So we held this, and I couldn't see in the end after I left the service if they investigated more things about that. But the emphasis that I was trying to put about the myelodysplastic syndrome and the bone marrow is that there is a correlation between the giant cell arteritis and the myelodysplastic syndrome. I don't know. I cannot go. I don't know how to go further regards that. I don't know if there is an association, like if the patient has the GCA could have the myelodysplastic or vice versa. But indeed there is. So yeah, that's a new and tricky
Wow.
thing for me also.
Thanks, Vinny. Just before the teaching points, I also just wanted to ask, do you know how the patient did subsequently?
Yeah, so he improved, and I couldn't see the discharge phase, but he indeed improved, like symptoms, the fever was resolved, and the levels of inflammatory markers they downtrended also.
Thank you. Glad to hear you got better finally. Sasan, take us home.
Sure. What a case, Vinny. Thank you so much for sharing it, and great discussion, Steph and Zaven. So we started with a 74-year-old male who presents with fatigue and recurrent low-grade fever. So we started the case with dealing with some complexity, and we learned that when we face an unclear path or to a diagnosis, or we're in a phase of uncommonness to a certain diagnosis, we have to try to distinguish between what's signal and what's noise, and try to take a step back and define our problem representation, look for localizing source, and reevaluate the whole history and look at prior data that could help us move forward. And here in our case, we were able to name our problem, which is systemic inflammatory syndrome. And moving throughout the case, we were considering vasculitis as a differential diagnosis, specifically giant cell arteritis, as it can present with fever of unknown origin. And looking back at the pathophysiology of this vasculitis is that most of the symptoms that we see are due to ischemic reasons and luminal narrowing that happens in the artery. And one of the lessons that I learned today is that to look at the whole picture of the patient, and the presentation of the patient really fits the presentation. Absence of certain characteristic features does not completely rule out the disease. So we have to keep that in mind. And we had some discrepancies here where the patient did it he had some recurrence of his symptoms even while being on low dose of steroids. And we learned from Dr. Zaven that some patients, when tapering their steroids, they could have some recurrence of their symptoms as well. And we have to really know the limitations of the investigations that we're going for, especially if we have a high pretest probability, or we're highly considering this diagnosis. So really knowing the limitations of what investigation you're using. And we learned from Vinny and the radiologist that absence of the halo sign on ultrasound does not rule it out as well. And we learned from Steph as we have a mimicker for GCA, which is VEXAS syndrome. And those are my teaching points. Thank you so much.
Thanks, Sasan. Thanks, Glenn, for scribing. And Vinny, thanks again for a really complex, interesting case with someone who felt better in the end, which is really important. So learned a lot today, as always, from all of you. Thanks for joining.
Thank you so much, everybody. Have a great day.
Bye, guys.